I'm Jennifer Carlisle, and I'm assistant professor at Emory University Winship Cancer Institute. Today, I'm going to be talking about how we rolled out Tarlatamab at Emory, which includes primarily outpatient administration through our Rollins Immediate Care Center. This is an advanced practice provider-run 24-hour clinic that lets us safely do the 24-hour monitoring that is on the FDA label for Tarlatamab without necessarily admitting patients who end up not needing admitted. So there were a number of steps and a number of parties to kind of get on board with rolling this out at Emory. Pharmacy, inpatient teams, the infusion center, and our immediate care center all had to kind of sit at the table to discuss how we were going to coordinate administering the drug in the outpatient infusion center, monitoring the patient there for a short time, transporting them to our ICC for the remainder of monitoring, where they would have nurses check their vital signs and ICE scores to look for ICANS at an interval of every 4 hours. And patients who develop toxicity outside of a grade 1 CRS, so anything more than a fever, are then subsequently admitted to the inpatient oncology service. This has been helpful in terms of kind of, preserving beds for patients in the hospital who need them, and not just doing admissions for patients who end up not having side effects. This has required coordination with the outpatient and inpatient APPs and making sure providers are all educated on CRS and ICANS and when to give extra dexamethasone or tocilizumab. At Emory, we're fortunate to have been a part of the initial Delphi 301 phase 1 clinical trial of Tarlatamab. So we've been giving this drug for a number of years and also participated in the outpatient portion of the initial phase 1 trial. So we were able to incorporate what we learned with that experience to help patients have access to this quickly with the FDA approval of the drug. So we report at ASCO 2025 data from 48 patients who received at least one dose of Tarlatamab. Our median age was 65. We had a female predominance. 23% of the patients included had an ECOG performance status of 2, which would not have been included in the initial clinical trial. This spanned patients who were both platinum sensitive and platinum resistant and had a number of prior lines of therapy. 37% had 1 prior line, 31% had 2 prior lines, another 20% had 3 prior lines, and then there are a few others. So among the patients who had enough dose for efficacy analysis, we found that the median progression-free survival was 101 days. And we saw CRS or ICANS in 29 patients, which is 60% of this population. 13 patients were directly admitted from the ICC for CRS or ICANS. So that gives you the remainder of those patients who did not require admission. I think there needs to be a couple of safety measures in place. One is for patients to have wallet cards. These are provided by the company so that should they end up in an outside emergency department, providers there can look up or familiarize themselves with what may be toxicities and, safety measures to mitigate some of those toxicities. We also provide our patients with a dose of oral dexamethasone to have on hand at home in case there are transportation issues or delays in being able to come to the center or somewhere for medical care. I think, we were able to successfully use advanced practice providers who are there 24/7 to provide the, advanced level of care needed to make decisions in terms of who needs to be admitted. So there does need to be a clear pathway so nurses know who to call should a patient develop, increased side effects. While the majority of patients' CRS is grade 1 and mild, it can get very severe, and there has to be appropriate ICU level of care that can be accessed expeditiously.